I'm a past president of the California Nurses Association, and I'm here to put a human nurse to patient perspective on the research that Dr. Schindel Rothschild has so eloquently outlined here. When I started my career in California, I graduated, newly licensed, worked my way through school, and had all of the education and initial experience I needed to practice competently. My first assignment was on a medical surgical ward where I had 15 patients on one hallway, and on the other hallway, the other RN had 15 patients. We shared an LV in between us to help pass routine medications and a couple of nurses' aides to help with baths. And the very first patient that was on my unit had come out of intensive care. She was 24 years old and had had an acute asthmatic attack. And she came to the medical surgical ward, and she was coming out of the shower, collapsed, struggling to breathe, and she died despite our best efforts because, again, there were only 2 RNs on that floor for 30 patients. And when you see somebody like that struggling, and you know they did for lack of sufficient numbers of qualified registered nurses on the ward to manage that acute outcome, you want to do something about it. And as nurses, we're not just going to whine about it when we see people struggling and dying needlessly in our hospitals. We want to do something about it. So I commend NYSNA and the legislators here this morning for wanting to implement safe staffing standards. Dr. Rothschild talked about failure to rescue, and the young woman who was 24 that died despite our best efforts. Was that necessarily our failure as nurses to see what that patient needed and try to bring her back? Or was that the hospital's failure to staff properly? I'm going to break down one of the really most significant statistical numbers that's been cited now in the research, peer-reviewed journals. For every patient above 4 that a registered nurse is requested to care for or assigned, there's a 7% increase risk of death and failure to rescue despite our best efforts in our education and training. So if I've got 8 patients, okay, 7 times 4, it statistically works out to about 30% increased risk that something bad will happen that was preventable for each one of those 8 patients that I've been assigned to care for. So that's why now the research has shown, and it's consistent now for the last 10 years, that these numbers, minimum staffing, and hospitals still, it's not a one-size-fits-all solution, have to staff up from the minimums based on the assessed needs of the patients for nursing care, and that assessment comes from the registered nurses who are doing the work at the bedside. And so I invite you to listen to the nurses today who are here to tell their stories about what's going on in New York. So in California, in 1976, we too started by having nurse-to-patient ratios mandated, were signed into law by then Governor Jerry Brown. And so I beat a path, got my training and certification, went to work in the ICUs. And then studies came out that showed and our ratios were initially no more than 2 patients per RN in the critical care units. And then studies came out that showed for every patient above 1 in a critical care unit, and this was after the AIDS epidemic started hitting, those patients had a 50% increase risk of something bad happening that was preventable or death, even at that level. So we worked to improve those ratios. Once the staffing law was passed in California, signed into law in 1999, as Dr. Schindel Rothschild had said, it wasn't until 2008 until the ratios were fully implemented. The hospitals had an opportunity because of grant funding to hire the additional staff. There was money made available for nursing education. I worked at Long Beach Memorial Hospital at the time that we struggled and fought for the nurse-to-patient ratio law. And we were invited, after that law was passed, to talk about the success hospitals had in hiring the additional nurses because of the funding that was made available. We were able to increase our staffing by 300 nurses. That was made possible because of a grant that the hospital received. And we formed part of a consortium with California State University in Long Beach to expand their capacity for nursing education and in pre-licensure program, where a lot of us that were the experienced clinical staff did the teaching, the mentoring, and the precepting of these nurses, and then we were able to hire the class where before this law went into effect, we didn't have nurses that were available. We were invited then, as members of the California Nurses Association, sought out by the Department of Health and Human Services, the Agency for Healthcare Research and Quality, AHRQ, in 2011, published, and you can go to the website under Staffing Innovations, the California Nurse-to-Patient Ratio Law, where it actually describes this process, what the law did, how the regulations were promulgated. They talk about the California Department of Health Services using the scientific method in order to determine what the ratios should be for each defined unit in all of the acute care hospitals in California. And they did a study, they commissioned a study by the University of California that did a survey of all the hospitals. They looked at what the existing staffing was, they looked at all of the research studies that had been published in peer-reviewed journals, and they brought in stakeholder input from all of the various stakeholders, the California Hospital Association, the Association of American Nurse Executives, the American Nurses Association of California, the Business Roundtable, and then they heard from the registered nurses themselves. And so this consensus, this coming together, getting input, everybody bought into the solution because by then everybody had seen that there was a problem. Everyone's life had been touched by a nurse. Everyone saw that there was a preventable harm and even death that had happened because there weren't sufficient nurses at the bedside. So now we do have the evidence. We didn't have it before. So there's been a significant amount of studies that have been done. So again, I'm just here speaking from my experience. Dr. Schindel Rothschild has done her homework, and she's not a member of our association. She's not a member of NISNA. So, you know, she's a third party that's got the skill and the education to critique the research, to show us what the staffing ratios need to be, should be, and they've been validated as a benchmark with a very strong evidence rating. Thank you.
Thank you. Deanne, I just have one question. So when you did increase the RN to patient ratio, what happened with the ancillary services?
That's a really very good question because hospitals will tell you, well, we have to make cuts somewhere. But the research has actually showed that hospitals have maintained their skilled nursing personnel. It takes all of us as part of our team. So there's been no cuts, and as a matter of fact, we've been able to continue to have a care team of workers, respiratory therapists, nurses' aides, unit secretaries of work, clerks, and pharmacy techs.
So we've had a lot of compelling evidence that safe staffing so far, cost-effective, better outcomes, and it's just the right thing to do. So my next, I'm going to introduce 4 panelists that are going to discuss this issue. First, Deborah Hayes, RN. She is the area director of CWA. Debbie Hayes is a former president of CWA Local 1168, where her unique leadership qualities and negotiation abilities gave her the ability to lead CWA Local 1168 through the merger of the Buffalo General Hospital with the Kaleida Health System. As director for CWA District 1, she fights for fair wages, benefits, and safety in area hospitals.
So, we've met already. I'm Debbie Hayes from CWA. I've been an RN for 37 years, and some of those years I've worked at the bedside, and for even more of those years I've represented healthcare workers in a number of facilities. CWA has about 12,000 healthcare workers across New York State, and regardless of where the nurses work, in what unit they work, the type of nursing they perform, the bottom line is that unsafe staffing is an issue for everyone. I haven't talked to a nurse that works in New York State that has said to me, everything is good on my floor and I don't have to worry when I go into work. This is particularly disturbing to me because the patients that are admitted to the hospital are much sicker than when I was working at the bedside. The unfortunate trend is that as patient acuity increases, staffing only gets worse, and we have to do something about that. We need legislation that establishes safe, consistent minimum standards of care because the status quo is not working. For decades, New York has allowed hospitals and nursing homes to determine staffing levels with virtually no oversight, and they are failing us as healthcare workers, our patients, and our loved ones. In New York, we have filed grievances, we have negotiated staffing committees, we have filed protest of assignment